All right, folks, I think we're going to get started. Everyone, grab a seat. So today we're starting our journal clubs by the Liver Fellows. And so Kieran's going to be leading us off here with two very interesting articles on induction therapy in liver transplantation and access to non-U.S. citizens to liver transplant. So thanks, Kieran.
Hi, everyone. So just as Jean said, I'm going to talk about two different articles. The first one is kind of personally interesting to me, and I think it's relevant for us here at Sinai since we do transplant a fair number of patients under PRU-call, which is basically patients who are not documented but state residents, and so they can get state Medicaid. And the situation is similar in a few states. So it's pretty difficult to look at these patients in a meaningful way, but I think that this study, they were able to look at outcomes in these patients using a national database. So I'll start with that one. So the background is that in terms of access to liver transplant, there's no actual guidance set by UNOS about who can actually access livers. What's the main guidance that we have is that it should be medically necessary, and that's about it. So each liver transplant center is allowed to set their own policy, and for the most part, the policies seem to follow location, and location as in which states allow undocumented immigrants to obtain Medicaid. So the reason they were able to do this study is because UNOS started to require recording of both citizenship and residency status. And the reason that they want to do this is because there was a growing number of transplant tourists that were being noted kind of in the press, etc. And they wanted to better understand these patients and kind of how many patients were getting transplanted as transplant tourists at each center. And initially their plan had been to audit every center that had over 5% transplant tourists, but that didn't really end up happening. But that started around 2012. And a transplant tourist, in case that's not clear, is someone who came to the US specifically for the purpose of a liver transplant. We've never transplanted a transplant tourist at Mount Sinai. Background, so there's not, just as I mentioned before, there's not a lot of data on outcomes in non-citizen, non-residents in liver transplant. So there's one study out of Penn, done by Dr. Goldberg, and they used UNOS data, they looked at from 2002 to 2016, and they specifically compared people who were US citizens and US residents to people who are non-US citizens and non-US residents. They excluded status 1 patients, which is important to know. And what they found in that study is that the non-citizen, non-resident patients were less likely to be removed from the wait list. They had a much higher risk of being lost to follow-up, and they had lower rates of post-transplant mortality. The kind of difficult part or the issue with this particular paper, those like novel data, they didn't actually differentiate between undocumented immigrants who are here and specifically for an organ. So not surprisingly, transplant tourists go back to their own country. So for this study, this study was done at between two centers. It's done between USC and UCSF. And it's done by I don't know if Brian Lee is here, our nemesis, the other Brian Lee. And he and Dr. Terrell, basically, they collected UNOS data for people who underwent transplant between 2012 and 2018. They specifically included international transplant tourists, since those were now identified in the database. And the way that they're identified is that either patients self-identify or a transplant coordinator is the one who kind of forwards that information. They then used the Pew Center research estimates, and they looked at the total population of undocumented or unauthorized immigrants in each state just in the year 2016 as a kind of baseline to compare the proportion of patients who were getting transplanted to the proportion of patients who were actually there. And they also looked at the country of origin of each undocumented patient. And one thing to know is that between this time period, 2012 to 2018, the population of unauthorized immigrants was roughly stable. So it's varied by less than 5% during that time period. So it should be fine. So methods. They excluded kids, excluded people with HIV. They excluded anyone who's had a prior liver transplant. Obviously, they excluded people who traveled to the US specifically for transplant. And then people who didn't have full data were excluded. For the last one, they excluded people with transplant after 2017 so that they would have enough follow-up data. So they looked at the baseline and characteristics at the time of transplant, not at the time of listing, but at the time of transplant. Their primary outcomes in the study were mortality and graft failure, which is defined as retransplant or death. And they used two different comparisons. One, they used a chi-square for just typical categorical variables. Wilcoxon rank sum test and a two-sample t-test for the continuous variables. All right, so this is their table 1. So there were a total of 43,192 transplants during that time, and of those total, 166 were non-U.S. citizens, non-U.S. residents. They basically tried to see how well the predictive value of the UNOS data was by looking at their own data from USC and UCSF. So they did this subsample validation where they did a chart review of the 41 people that were transplanted at those two centers. They went through their chart and looked to see where they're actually from and what their status was. And the algorithm that they had used turned out to be 93%, have a 93% positive predictive value. So 38 of the 41 people at their centers were actually undocumented immigrants. So to look at this table 1, so the non-U.S. citizens, non-residents were significantly younger than the U.S. residents. They were significantly more likely to have Medicaid as the payer of their liver transplant, which is somewhat obvious. They're most likely to be Hispanic and Asian. They're more likely than the U.S. residents to have lower educational levels, more likely to have RRT, and their MELD was significantly higher at the time of transplant, which is 29 versus 21, which is a pretty big difference. Let's see. Next one.
Sure, before you go further, did you see whether they quantified the percent missing in terms of document status, legal status? You can imagine that could be something
that is left
be quite a large
empty.
number. It's not clear. It's a sticky issue, but I don't remember seeing it.
I didn't see it, and I don't think it was in the supplemental tables either. And that you're right, that's a huge issue because probably to protect patients, especially in states where this is not typical, they may have just left it empty. This is basically a table that looks at the recipient characteristics at the time of transplant, and the most important, or really the only thing that was different is that, I'm missing this thing from the top, but this group is the non-citizen, non-US resident group. They're more likely to have hepatitis B as the indication for transplant. So this figure looks at one of the things that they wanted to look at was whether there was a difference in access between states. And this figure shows us that there was, that California accounted for about 27% of the total US population. and New York accounted for 7%. But when you actually look at how many transplants were actually performed, there's a much higher difference in proportion for the California and New York population. So so in kind of simpler terms, more people, more non-citizen, non-resident patients in California and New York were transplanted as compared to their actual population in that state, versus Texas and Florida, there were fewer. This basically just shows the most common countries that patients were immigrated from. So they're Mexico, Guatemala, China, El Salvador, and India, and this reflects the US immigrant undocumented population as well. So it's pretty similar. So these were the two primary outcomes that they looked at. One was the risk of graft failure, and they found that their immigration status was not associated with the risk of graft failure. Although I didn't show this data, but these patients were more likely to be lost to follow-up, so there is some missing data there. And the other outcome was the risk of patient death. So they found that their immigration status was not associated with the risk of their death. I'm trying to show it. There we go. So overall, some of the other things that they found were that the proportion of people who got liver transplants who were undocumented immigrants was low compared to the rest of compared to documented patients. The survival between the groups was similar, and there's a disparity in access to transplant across states. Some of the limitations of the study. So one big one that Jean kind of brought up was misclassification. So all of this info that we have is based on self-report or data that was entered by transplant coordinators. So we could be missing data, possibly to protect patients. And the other issue is that we don't have data on all the patients who were evaluated. We only know the patients who were successfully, like, went all the way to transplant. And you have to imagine that there must be a selection bias in this group, because just clinically, I doubt that full evaluation and listing would happen for patients who aren't perfect candidates if they're not documented. And they're not status 1, since those patients were excluded. So overall, this study showed that liver transplant in undocumented immigrants or unauthorized immigrants overall are rare, and it's a very low proportion of the total transplants that we do in the United States, at least during this time period of 2012 to 2018. The access to liver transplants in these patients is variable across the states, and seems to be, they don't really mention this in the article, but seems to be related more to how states use their federal Medicaid funds and whether they use them for unauthorized immigrants. They found that there are patients who are lost to follow-up, but patient and graft survival are comparable. So overall, my conclusion from the study was that considering that these patients might have worse survival shouldn't be a reason to deny access to liver transplant.
Thank you. A point that's brought up, because this can be controversial or sort of emotional topic, is that the study is able to show that when you remove the tourists, transplant tourist patients, that patients do equally well. But also the non-U.S., authorized patients who are residing in the U.S. also contribute to the donor pool, too, right? So there is sort of a give and take in terms of that, that they are unauthorized. So we don't necessarily not accept organs from these patients because because they don't have authorization to be in the U.S. We're glad they accepted those organs as well. So,
Yeah. So there's a big disconnect. Well, maybe not that big, but there's a disconnect between those two. So the only data that we have is from UNOS from 2016, and that year they accepted 3.3% of all organs that were transplanted into people were from undocumented people. And if you compare that to the 0.4% that they're getting, there's a bit of a disconnect. You guys have any questions?
Did they report on you might have mentioned this, the I guess, proportion of patients who were evaluated but turned down, the difference between the two groups?
They didn't, because they used, so I think that's a super interesting question, and I found at Sinai it's really hard to find because it's very much hidden in the charts. Nobody's really keeping track of who's been evaluated, who hasn't, but they used only people who underwent transplant, so they don't have any evaluation data.
I guess it seems like that would probably be much higher in the studied group. I know here, like if they're evaluated, that might signal to the government that somebody's here who's an unauthorized data entry, and therefore you don't want to evaluate them unless there's a very high chance of them actually being consumed.
Yes. It's not captured in this particular data because it's just kind of like national data, but that's true. So to actually apply for Medicaid as an undocumented person, you have to prove that the U.S. government knows that you are here and isn't actively trying to get you out.
That probably keeps a lot of people from seeking medical care.
Yes, and I think it's probably variable depending on the administration that we're under.
People lost the follow-up rates because they were lower. It looked like at 2 years, 30% dropped out of the non-medical. Which one is 60 for non-medical?
Where are we looking?
Versus 10%.
So,
At 118, right? And then 95.
no, they weren't. So 7 of 118 people from the non-U.S. citizen, non-resident group, which was like 6% or so, was lost to follow-up after they had like different for each group, but for that group they had 1.85 years was the time that they they looked and they had the data. So 6% at that time, and then the other group was only 0.9% at 2 years. So there was a difference, and it was significant.
So I have a question about how is it determined that a patient can get a transplant or not based on their status and insurance coverage in these patients, the population that we're talking about in this paper?
So they don't really go over how each patient was chosen at a center level, because each center can make their own decision about who to list and who not to list. They also don't really talk about the reasoning behind which states are most likely to do these transplants, but the 4 states that are most likely are 2 of them have state Medicaid programs where undocumented patients can access care. That's California and New York. And then 2 of them are just states with a lot of migrants, which is Florida and Texas. And those states, for example, Texas has actually, they've kind of tried to move towards not having the ability to enroll in state Medicaid programs for those patients. So you can see the disconnect between the access versus the amount of people there.
I don't think neither Florida nor Texas did the Medicare expansion either as part of the
Right.
ACA.
Right.
Whereas New York and California did.
Yeah, so there's a lot of policy stuff behind this.
But even in California, for example, if you have like undocumented patients, can you get this for anybody? I mean, I'm assuming that's not the case, right?
So
How is that determined?
I think it varies by state. I only know New York's, but actually Medi-Cal, which is their state Medicaid, I think that they made it available to all undocumented people. So I don't know if that will let you get a transplant, but the state Medicaid will cover transplant, whereas federal Medicaid won't. All right. Next one is not really about policy. This one is about the use of induction therapy in transplants. So this study is a Penn study, and they are using national level data as well to look at post-transplant outcomes in patients who have different types of induction therapy versus no induction therapy. So we'll go over what induction therapy is too. So induction therapy is basically, there's different types of it, but it's where you use a very strong immunosuppressant or a depleting, like a B cell or a T cell depleting agent to decrease the idea is to decrease the risk of acute rejection or to be able to use a lower dose of a calcineurin inhibitor. So the goal of using a less dose of a calcineurin inhibitor is to kind of spare renal function in these patients for their chronic immunosuppression. There are two kind of different types of induction therapy. One is non-depleting induction therapy, so that doesn't deplete B cells and T cells, and the depleting induction therapy is felt to be associated with a higher risk of infection. Those are things like anti-thymoglobulin and rituximab and alemtuzumab. So the background of the study is that there are these proposed benefits of using induction at the immediately after transplant. Most of the data for induction therapy comes from kidney transplant. There's not a lot of data in liver. And the idea, as I talked about, was sparing the kidney by decreasing the amount of calcineurin inhibitor needed, reducing the risk of acute rejection, and then reducing the need for steroids. The background for this is that the AASLD doesn't have any consensus statement at this point about whether to use induction therapy or not. It's different in the Asian guidelines and EASL. We don't have it.
Shocked. ASLD is fine.
No comment. And yes, but the EASL guidelines say to use non-depleting induction therapy in anyone who has renal dysfunction, and the Asian guidelines say to use it in everyone. But we don't say it either way. The other thing is the older studies that compare induction therapies are something like 20 years old, and they don't account for a lot of the changes that have happened. So in the past, we transplanted patients with Hep C who were viremic. They had much different outcomes when they had induction therapy, as in it's been shown that they have worse outcomes. And we are also transplanting older patients who are presumably more at risk for infection. So the goal of this study was to look at we actually talked about this at a recent talk, and the goal of the study was to see what the variability among centers was in the United States between use of different types of induction therapy. So they wanted to compare the effectiveness of the depleting versus non-depleting, and they compared this to no induction therapy for the most part. And they wanted to look at a national sample of and look at the outcomes of mortality, graft failure, renal function, and episodes of acute rejection. Let's see. So this was a retrospective cohort. They used UNOS data from 2005 to 2018. They only looked at adults. They used similar statistical models for different variables similar to the other studies, so chi-squared and Wilcoxon rank sum tests for both. And they excluded people who had had prior liver transplants. They excluded people who had multivisceral transplants because obviously the immunosuppression is different in those patients. They excluded centers that performed less than 5 transplants a year, and they excluded anyone who used any alternative agents. So the ones that they kind of included were, for non-depleting agents, were daclizumab and basiliximab. Depleting was thymoglobulin, alemtuzumab, and Ritux. So the primary outcomes were all-cause mortality, graft failure, the change in EGFR, and they looked at the change at 6 months, and then they looked at biopsy-proven acute rejection in the first year as reported to UNOS. So anything that wasn't reported wasn't recorded, similar to the other study. So in terms of the characteristics of the recipients, the total number of patients that they looked at was about 69,350 recipients. They looked at 114 different transplant centers. And you can see on the depleting and non-depleting side, about 18,000 or so patients got some kind of induction therapy, and 50,000 got no induction therapy. One thing that I'm not showing on this table 1, and they didn't have a figure or table for this, but they did record at the very minimum what kind of immunosuppression was used along with the induction therapy, and it was significantly different for each type of strategy that was chosen. So for non-depleting patients who got non-depleting induction, they were more likely to have be discharged on calcineurin inhibitor, steroid, and a immunomodulator. Whereas patients who got depleting therapy had all kinds of they were very heterogeneous in the types of immunosuppression that they're discharged on. So that kind of clouded the data. So this is a very pretty figure, but it's kind of confusing. So this is just showing the amount of variability between each center in the U.S., and this is at the 114 centers that we talked about. It's not over time. And it showed, let me see, I wrote it down. It showed that most of the centers used no induction for the most part. And then of the centers that used non-depleting, it was something like 60% used, or for the centers that used induction, about 60% used non-depleting. Some data that they didn't show was the use of non-depleting agents increased pretty significantly over the time period that they looked at. So from 2005 to 2006 or so, the use of non-depleting agents doubled. The use of depleting agents didn't change. So I only actually put 2 different results on here. I didn't think that and I'll talk about why, I didn't think that the renal outcomes were very significant. So the only 2 that I put up here were the survival and the number of biopsy-proven acute rejection. So in terms of the survival results, for adjusted probability of survival, the absolute difference between the groups was pretty small. The adjusted hazard ratios for non-depleting agents was 0.9 compared to people who didn't have any induction therapy. And the adjusted hazard ratio is 0.91 in depleting agents compared to people who didn't have any induction therapy. So the absolute difference was really tiny in terms of survival. The one thing that was significant was episodes of biopsy-proven acute rejection. So in the patients who got non-depleting induction therapy, they had a decrease in 12% odds of rejection. There was no difference in the patients who got depleting induction. So that was literally the only positive study, in my opinion. And the other results that they showed, but that I didn't show, was that they looked at renal outcomes at 6 months. So they looked at EGFR at 6 months post liver transplant, and they used that to kind of predict 1 year EGFR. But in terms of the actual 6-month data that they had, the difference was an increase in EGFR for both NDI and DI. So basically both non-depleting and depleting agents was an increase in GFR of 3.8, which is really not clinically significant. I didn't include it. All right, so what this study showed was that there was a really small improvement in patient and graft survival when you use induction at all, but the absolute difference was very small. They did show that the renal outcomes were better. The difference in GFR was something like 3.8 in the adjusted group, but that to me seems very clinically insignificant. They showed that that non-depleting agents did decrease the risk of rejection in the first year, and that it was a stronger effect in younger patients. However, this doesn't reflect a lot of things. It doesn't reflect the fact that the patients who had non-depleting induction had a completely different immunosuppression regimen than the other groups. The other thing that the study doesn't include, which I think is clinically significant, but they're not able to get this information from UNOS, is that they couldn't evaluate at the individual level what risks could potentially be associated with using induction therapy, mostly infections, things like CMV, and post-transplant lymphoproliferative disorder. They weren't really able to evaluate the severity of rejection either. All they were able to show was that the patients had biopsy-proven acute rejection. So it's not clear how clinically significant that is either. As I just discussed before, it's kind of difficult to separate the effect of the induction regimen from the actual maintenance regimen. Another reason that I thought the renal information was not so significant is that you are not able to tell whether patients were on dialysis or not post-transplant from the UNOS data. And they're missing a lot of data from, especially from the renal portion. So overall, my conclusions from the study was that it's not clear to me that there's actual clinical benefit across all groups, at least in terms of liver transplant. And I wonder if part of that is because the liver is more of an immune tolerant organ than a kidney. And I think that something that would be pretty interesting would be to look at certain subpopulations, for example, patients with autoimmune hepatitis or patients who are more likely to have rejection in the first year, and look at their outcomes kind of in a sub-analysis. And also to look at the cost-benefit analysis, because it's incredibly expensive to do induction therapy with what seems to me to be pretty minimal benefit.
Karen, question for you. Did you come across, or in comparison, just look at, like, let's say, the renal literature for intervention like initiation of ACE inhibitor therapy, what an expected clinically relevant change in EGFR might look like? It's something that is more accepted, because it's hard to know
what 3 means.
I'm not a nephrologist, what really that means. I agree, it doesn't seem like a lot, even though it's has a large p-value. So it'd be interesting to know how that would compare to like ACE inhibitor therapy in a diabetic, for example. If that is only 5 or 6, then maybe it actually is more impressive than we think. If that's more like 20, then you're right. Maybe 3 is not very much. So that's something to think about in terms of present data that's the hard to interpret.
If you're looking at the graft survival, I think it's also interesting to see what's going to happen in the DAA era, because you're kind of masking the Hep C effect.
Right.
I think they didn't. Yeah, maybe they didn't have enough follow-up.
I think their goal was to look at it, Yeah, they didn't have enough follow-up from the post-DA era. Excuse me.
I mean, do they do any sub-analysis to look at, they say it's very, very center specific, where you get your transplant seems to dictate a lot about whether you get induction therapy, right? So if they narrow down to those who use primarily induction therapy, it'd be interesting to see if that patient population is a little different, perhaps, where induction therapy
At that
makes a
center.
lot more sense. Let's say in Texas, they tend to use that a lot. The organs may be different, the MELD scores may be different. You just focus in on the top 10, let's say, centers. That would be interesting compared to the top 10 centers that never use induction therapy. Maybe that can give us a sense why there's such a variation in practice.
Yeah, that makes a lot of sense. They didn't identify the centers or do that, but it would be interesting to look at, for example, like MELD scores and ages and see.
I mean, they show some of that.
They
But
did
that's
some
kind
of
of like that's the whole group, though.
Yeah.
It's kind of muddied by other things.
Any other questions?
Okay. Thanks, Karen.
Great work.